Good afternoon, all. I welcome you all for the first and ever conducted Teachers of Tomorrow program. Today, we have about 5 teams, and they will be presented as if they are teachers. Each presented is allotted 4 minutes, and he will have to answer 3 questions. So, today's judges are Dr. Aniruddha Nalvilkar, Dr. Harish Raichur, and Dr. Shruti Shirwadkar. Welcome all the judges.
Hello.
And the coordinators for this program are Dr. Kunal Nikale and Dr. Manish Bapai. Welcome, Dr. Kunal, Dr. Manish, welcome. So straight away, I will ask Ankita Patel to share her screen and go ahead with her presentation.
Yes, sir.
Admin, once the Ankita starts, please start the timer. Dhanalakshmi.
Yes, doctor. Yes, doctor.
Yeah. Once he starts, you can start the timer.
Okay. So shall I start?
Yes, Ankita.
So, sir, I'm going to start my presentation.
Yes. You should start sharing your screen first.
Sir, it is already there.
No, let it come. Where it is not.
Okay, sir. Wait.
Yeah, Ankita, you can start now. We can see your screen.
Yes, sir.
Then Lakshmi, please start the timer once he starts.
Okay, doctor. Yes, sir. Very good afternoon and happy Independence Day to all. Myself, Dr. Ankita Patel, Junior and from SBHMC Dhule. I am going to present my topic under the guidance of Dr. Vaishali Unay ma'am, Professor and Head of Department. So, I am going to present a very fascinating topic, that is ophthalmic viscosurgical devices. So, these are also called as third hand of a surgeon, and these are the important surgical tools nowadays in ophthalmic surgeries. So, what is ophthalmic viscosurgical devices? These are the transparent gel-like substances having viscous and elastic properties. The term viscosurgery was coined by Dr. Balance, and sodium hyaluronate was first used as a viscoelastic agent in ophthalmic surgery in 1972 as a replacement for aqueous and vitreous humor. So, in short, we will see properties. Elasticity. It is the ability of a substance to return to its original shape after being stressed. So, it allows the entry chamber to reform. Now, viscosity. It is the resistance to flow, which is determined by its molecular weight. So, it indicates its protective and lubricant action of the ovids. So, plasticity. It is the ability of a substance to transform from gel into liquid under pressure. And surface tension. It determines the coating ability of ovids. Means low surface tension will have high coating ability. So, elastic agent. It should be optically clear, should maintain obstruct the access flow but interpret with instruments. So composition, it can be made of either sodium hyaluronate, chondroitin sulfate, hydroxycarbonyl cellulose, or any of these combinations. Classification. OVDs are classified on the basis of their viscosity. High viscosities are cohesive OVDs, low viscosity, dispersive OVDs, and viscoadaptive OVDs. So let us see the difference between cohesive and dispersive OVDs. Cohesive OVDs have high viscosity, high surface tension, and high pseudoplasticity, and they have low molecular weight. So they adhere themselves through intramolecular bonds and resist breaking apart. So these are used to maintain the antechamber depth during procedures like capsular access, IOL implantation, and enlarge the small pupil. Examples are non-GB. While dispersive, they have low viscosity, low surface tension, low pseudoplasticity, but high weight. So they adhere well to the external surface like tissues and tend to break apart easily and cause the endothelium. So these are used during procedures like emulsification and cortex. So this is the image, the first image showing well-formed structure which adheres to strong intermolecular bond indicating cohesive nature. While second, it is spreading like a liquid into the surface, so it is more like a dispersive. So what are viscoadaptive OVDs? These are the agents which show behavioral changes at different flow rate. Means these will show properties of cohesive as well as dispersive. At low flow rate, there will be more viscous and cohesive nature, so maintain the temperature better. But at high flow rate, pseudo dispersive, thus protect the endothelium. Example, Thelon 5. So it is a full spectrum of this. The image shows dispersive, which are more liquid. So coat the endothelium and partition. While cohesives are more solid, so maintain the space and pressure. While combination of this will be mixed OVDs. So clinical uses, these are used during cataract surgeries to protect the endothelium, maintain the anterior-chamber depth during fake emulsification, shoulder access, and eye implantation. Glaucoma surgeries, these are used during discocanal maintain the chamber depth, protect the endothelium. The posterior segment surgery or host to provide temporary effect, and in disco anesthesia. What is software? So it is so but it misses their drawbacks. These are used in conditions like floppy iris syndrome, where this viscoelastic agent hold the iris of the procedure. In cases with broken myopia. So this is a soft shell technique in which we will first insert the cohesive, which will maintain the antechamber, and then we will insert the dispersive, which will coat the entire endothelium. So removal of ovaries, it can be done by other documented method, more commonly used by us by manual irrigation and aspiration technique. Complication following overdose include post-operative increase in IOP, which is most commonly due to increase in mechanical resistance at reticular network, visualization of iris surface, calcific band keratopathy, more common with concurrent surface, calcific block syndrome when the ovid in the closed anterior chamber, and pseudo anterior uveitis. So it's like charges it carry. It maintains the RBCs and inflammatory cell inside the anterior chamber, and it gives anterior uveitis like condition, but it is the anterior uveitis. So thank you.
I think your time is over. You just have to rush
question.
through. You can finish within few seconds, I think.
Yes, sir.
Finished? I request judges to ask some questions.
Yeah, Vivek, first and foremost, I didn't have good clarity. Is it only for me or others are okay with the clarity?
Same here, sir. Even for me, the clarity was not so, like the audibility of the video was not.
Yeah, yeah. So I think that's why I missed a few points here and there. Anyway, we have to get on with it.
So the problem is with the internet they are using.
Yeah, yeah. So okay.
Secondly, I'm not seeing timer here. Could anyone see a timer on the screen on the meeting? I could not see the timer.
I also didn't get the timer.
There was no timer. That is why I just had started my own timer.
Okay, that's good.
Dhanlakshmi, can you start the timer on the time?
Yes, doctor.
Yeah.
Yes, doctor.
So it was
I'll
not
just
visible to us.
yeah. Ankita, hello,
Yes.
Dr. Ankita.
Yes, sir.
So now you are
Yes.
explaining this. I just want you to explain in very simple words the soft shell technique to a person who is hearing it for the first time, so that he understands exactly what you mean by soft shell technique. As a teacher, I want you to explain it as a teacher. Say with an example or whichever way you can. Have you understood me?
Sorry, sir.
Have you got my
Hello?
question?
Dr. Ankita, you
Ankita,
have
did
to
you follow?
explain it.
As a teacher,
soft
I
shell
want you to
technique.
explain. Yeah, soft shell technique in very simple words to a person listening for the first time. In your own way, with an example or either way,
Okay,
whichever way you want. Yeah.
Yes, sir. So soft shell technique, we have both cohesive as well as dispersive oviduct. Cohesive have their own benefits and dispersive as well. Cohesive helps to form the anterior chamber and they can be removed easily, while dispersive will protect the endothelium. So we will use in combination of this both. Like when we are going to start surgery, we will first insert the dispersive oviduct, we will put the endothelium, and then we will insert the cohesive oviduct. But after removal of nucleus and cortex, we will first insert dispersive and followed by cohesive oviduct. So like that, we will get the benefit of both and we will minimize their drawback.
Okay. Okay, thank you.
Nalgekar sir,
Yes, sir.
do you have any question to ask her?
Actually, I missed a lot of audio that she had. It's okay. So, what happens if you leave the viscosurgical device in the eye after surgery? A little bit of it. Ankita, can you hear me?
Yes, now I can hear you, sir. Sorry, sir.
Yeah. So the question is, what happens if you leave some of the viscosurgical device in the entry chamber after you finish off your surgery?
Sorry, sir, I don't get question.
You're doing surgery, you have used viscoelastic for the surgery and you closed it, but you left some of the viscoelastic unknowingly in the entry chamber. So what would happen to the patient?
Yes, sir. Yes, sir. Yes, sir. Sir, if the viscoelastic remains, it can block the trabecular meshwork and it can cause post-operative increase in intraocular pressure.
Okay, good.
Or it can use the pseudoantiuveitis like I said. These viscoelastic particles also carry electrostatic charges. So RBCs and inflammatory cells will remain in the anterior chamber, which will give inflammatory reaction in anterior chamber.
Okay, good.
Okay.
Correct.
Yeah. Can they give any surprise, refractive surprise, leaving viscoelastic behind?
Yes, sir. We can get the patient can have induced myopia because it will displace the lens IOL anteriorly. So
Okay,
the
good.
patient have patient can see the distant vision not so clearly, but near vision will be improved.
Good, very good.
Dr. Shruti, do you want to ask her any question to her?
Yes. Ankita, apart from intraoperative use, where plastics elsewhere in ophthalmology?
Yes, ma'am. Sorry,
Apart,
ma'am.
apart from cataract surgery or any intraocular surgery, where else can you use elastics? You got it, no?
If the yes, ma'am. It can be used in keratoplasty surgeries
Okay.
or posterior segment surgeries.
Apart from
Or
ocular surgeries, I meant to say, apart from any surgery,
okay.
can you use it elsewhere?
Okay. If there is a severe corneal cirrhosis is there, it can be used to lubricate the cornea.
Okay. And
It can also be used as a visco anesthesia.
like how?
When it is combined, means if 0.3% of sodium hyaluronate is combined with 2% lidocaine and when it is used, then it will prolong the duration of anesthesia and intracameral injection will not be needed in that case.
Okay. Anywhere else in any OPD procedure, can you use it?
Yes, ma'am. During gonioscopic procedure, we can use it.
Okay. Okay, fine.
Even lasers, I think. Good question, good answers. So next team is ready. Dr. Ria and Dr. Saurabh are ready. Hello.
So Dr. Nikita will present from Bausa Hire.
Okay, no, Nikita is
Second
there.
presenter.
Okay. Yeah, please. Nikita, please go ahead with your presentation.
Yes, sir. Yes, sir. Yes, sir.
If my screen is visible, sir?
Yes, yes.
Hello. Sir, my screen is
No, it is getting started. It is not yet visible. Yeah, it is visible now.
You can start now, Dr. Nikita.
Can I start, sir?
Yeah, sure. Start. Dhanalakshmi,
Slideshow.
once he starts, please start the timer.
Okay, doctor. Slideshow. Make it slideshow.
Just a minute, ma'am. First of all, very good afternoon to everyone. I'm Dr. Nikita Vasavi, Junior Resident in SBHGMC Dhule, presenting the topic of congenital ptosis under guidance of Dr. Vaishali Une ma'am, Professor and HOD, Ophthalmology Department and SBHGMC Dhule. So let's start with it. Ptosis is a Greek word which means act of falling. It is defined as a drooping of upper lid, usually due to paralysis or defect in development of the levator palpebral superioris. Drooping is up to a level that covers more than 2 mm of the superior cornea. Ptosis is generally unilateral and cover in about to 70% of the individuals. Let's start with the classification. Ptosis is classified in a congenital and acquired. Congenital is further classified as simple and complicated. The complicated is associated with maldevelopment of the surrounding structures. Acquired is further classified as neurogenic, myogenic, hyperneurotic, and mechanical. Let's start with the congenital ptosis. It is characterized by abnormal drooping of the upper eyelid that is present since birth or occurs within the first year of the life, and it results in the reduction of the vertebral palpebral tissue. The etiology is hypoplasia or dystrophy of the levator palpebral superioris associated with anomalies of genes PTOS1, PTOS2, and ZFH4. The pathogenesis is it results from the failure of neuronal migration and development of the muscular sequelae. The signs are unilateral or bilateral ptosis of variable severity, absent of upper lid crease and poor levator function. In down gaze, the ptotic lid is higher than the normal because of poor relaxation of the levator muscle. This is in contrast to acquired ptosis, in which the affected lid is either at the level or the lower than the normal lid on down gaze. The following surgical correction, the lid lag in down gaze may get worsened. The associations are superior rectus weaknesses may be present because of its close embryological association with the levator. Compensatory chin elevation in severe bilateral cases is seen, and refractive errors are more common and more frequently responsible for the amblyopia than the ptosis itself. The Marcus-Gunn jaw winking syndrome. About 5% of all the cases, congenital ptosis are associated with the Marcus-Gunn winking phenomenon. The retraction of the ptotic lid in conjunction with the stimulation of the ipsilateral pterygoid muscle by chewing, sucking, opening the mouth, and contralateral jaw moving, as you can appreciate in the image. The next is blepharophimosis, ptosis, and epicanthus inversus syndrome. It is a complex of eyelid malformation with a moderate to severe symmetrical ptosis with poor levator function, telecanthus and epicanthus inversus manifesting with small palpebral fissure. It is inherited as an autosomal dominant disease. It is caused by the mutation in the ApoXL2 gene on the chromosome number 3. The treatment is initially involves correction of the epicanthus and telecanthus followed by bilateral frontalis suspension. It is important to treat amblyopia, which is present in about 50% of cases. The treatment, surgery is the treatment of choice carried out between 3 and 5 years of the age if ptosis is partial. The procedures involved are first is the conjunctiva Mueller resection. In this, involves the excision of the Mueller muscle and overlying conjunctiva and reattachment of the resected edges.
Last 1 minute left.
The levator advancement or levator resection. In this technique, the levator complex is shortened and through either an anterior or posterior conjunctival approach. The third is brow or frontalis suspension, where brow or frontalis suspension is used for severe ptosis, where it is more than 4 mm, or either with a very poor levator function that is less than 4 mm.
Yeah, you are right on the time. I request judges to ask her some questions. Harish sir?
Yeah.
Okay.
Shruti, go ahead.
Okay, Nikita, nice presentation. So can you tell me before ptosis surgery, actually, we take Bell's phenomenon also. We check the Bell's phenomenon also. Why is it so? Is it important? Nikita, can't hear you actually.
Ma'am, can you repeat the question, ma'am?
Yeah. So for the basic ptosis evaluation, before the posting patient for any ptosis constructive surgery,
Yes,
we
ma'am.
check the Bell's phenomenon. So why is it important to check?
Yes, ma'am.
Did you get my question?
Yes, ma'am. The Bell's phenomenon. Yes, ma'am.
Yeah.
Yes, ma'am. It is necessary to check the Bell's phenomenon because after surgery there is a risk to get exposure keratopathy uh, while sleeping. If we can't check the Bell's phenomenon properly, then we can land the patient post surgery to the exposure keratopathy.
Okay.
Exposure keratopathy.
And how is the
Nikita,
normal Bell's? Just one small.
yeah, please.
How is the normal
Yes,
Bell?
ma'am.
How is the rotation of the eyes?
Outward and upward, ma'am.
Okay. Sir, please go ahead.
Yeah. Can you tell me something about pseudotosis and how is it important?
Yes, sir. Sir, pseudotosis is the condition where it is because of the in upper lid tumor or upper lid means acquired condition is there. It is not the true ptosis. That is because of some upper lid inflammation or periorbital edema or any tumor that can lead to drooping of the eyelid. It is not because of the abnormal levator palpable function.
You have to read upon it. Okay, Anil, please go ahead.
Yeah. So to further Harish's question, how would you differentiate between a pseudotosis and a true ptosis? Can you do that? Like suppose the microphthalmos or enophthalmos can cause a apparent ptosis which is not there.
Yes,
So
sir.
is there any
Pseudotosis can be caused by microthalmus or thysis
right,
bulbae.
absolutely. So okay, can you differentiate between true and pseudotosis? Is there a test to do it? See, you
Can
know
I
Hering's
repeat the
law of
question
equal
again?
innervation?
Yes, sir.
Yeah. So what the patient is doing is trying to lift the ptotic lid in true ptosis.
The other eye, yes, sir. It is
Absolutely. So you lift the
the
ptotic
other
eye,
eye patient
the
used
above
to.
lid drops down. Okay.
Sorry. Yes, sir.
Nikita, you can hear me?
No, sir. Hello.
Whenever there is ptosis, the patient
Yes,
will try to lift the ptotic lid, right?
yes, sir. And because of yes, sir. And because of that, the other
The
eye,
left
which is
lid will
normal,
be
the
retracted more,
yes,
other lid. Hmm.
yes,
So if you
retracted
lift the
more.
ptotic
Yes,
lid
sir.
with your finger, the other lid drops down.
Yes, sir.
Okay. It's a good presentation, Nikita.
So it was a nice session. I think Dr. Vaishali Gune, madam is there. Madam, you want to say anything?
Yeah, I thought it was my exam itself when the examiners were asking questions. I was sitting on the edge. I hope my students answer well.
That done well, madam.
They did well.
Thank you, sir. Well, we can guide them to a level, but then finally their own skills as teachers should come up. So I'm sure this Teachers of Tomorrow episode is a very wonderful venture by MOS, and I thank the organizers for this. Thank you.
Thank you.
And I think your students did proud to you. They're good.
Yeah, they did very well, Vaishali.
Thank you.
Yeah, yeah, they
Thank
did.
you. Thank you, sir. Thank you so much.
I just want to know whether SMBT team is ready. Dr. Saurabh and Dr. Riya.
Yes, yes, sir.
So you can start sharing. You just try sharing. We'll give some time to you because you're not done the trial.
डॉक्यूमेंट आपका जो भी नाम
Meanwhile, Dhanlakshmi,
Yes.
we are not able to see any timer on the screen.
I
So is
stopped
it
the timer, doctor.
Pardon?
You not see?
No, we are not able to see.
No.
1 second.
And even the clarity needs to be worked on a little. I don't know.
Doctor, I've just run the timer as a sample for you.
No,
on the
now I
screen.
can see. I
You
can see
now
that.
it is.
Yes.
Doctor, can you hear me?
Yeah.
Can you see the timer on the screen? On the right top, you will see
Yeah.
with the blue
Yes,
color
we have
icon.
Yeah.
Yeah. Okay.
Yes.
Yeah.
So it should be visible while they are presenting.
Yeah. See, it will be visible while they're presenting. They just have to have an eye on the right side top. That's all.
Yeah, now it is visible. Yeah, you can get a trial. We'll give you time because everybody has got a trial.
Yes, sir. Can you see my PPT presentation?
Presentation is not seen. But present
Not
it
yet.
is very small. You have to enlarge it. It is seen in a very small. Yeah, now you can see the examination of optic disc. Yeah. So try sharing the slides. Yeah, now you can share the slides too. So are you ready? Should we start or you want to try?
1 second, sir. Yes, 1 second.
Yeah. Take your own
Yes,
time.
can you see, sir?
Yeah, we can see it very well.
Is it visible?
It is
Okay.
clearly
Okay, sir.
visible. You are
Am I audible and
you are,
visible?
audible also. Yeah.
Okay.
The timer is not
Good morning, respected jury.
Yeah, you are starting.
Yes, sir. Good morning,
Dhanalakshmi.
respected jury.
It's doctor. I start.
Yeah. Timer. Yeah. Start timer. Yeah.
Yeah.
Go ahead, Riya.
Myself, Dr. Riya Udhani, PG resident at SMBT Institute. I am present here today because teaching is my passion. So my aim for today's lecture is when you're examining the patient who has full faith in you, and if you're able to detect those early changes on time and prevent that person from becoming blind, you're not only saving the person, but his entire family. So without any further delay, let's begin with the session, that is optic disc examination in glaucoma. Optic disc is the heart of glaucoma evaluation, as 30 to 50% patients have normal intraocular pressure at the first visit, and many ophthalmologists have no access to perimetry. There are various techniques for examination of optic disc, but nowadays slit lamp examination with 90D or 78D convex lens is most important. Evaluation in optic disc in glaucoma can be easily remembered by 5 H's. First, height of disc and cup. It is recognized that absolute value of the cup disc ratio is meaningless, as the cup size is dependent on the disc size. Large discs have large cups, and a very small disc having a CDR ratio of 0.4 may indicate glaucoma. So how do we measure disc and cup size? First, identify the Elshnik scleral ring, which is the border of the optic disc. The slit beam is adjusted so that it aligns with the inner margins of the ring, and the reading of the slit height is multiplied by a correction factor depending on the power of the lens used to give the optic disc size in millimeters. Alternatively, you can use a direct ophthalmoscope to project a light spot. While measuring the cup, shouldn't be measured. It is determined by change in the direction of the vessels at the margin. The vertical elongation of the cup should be determined. the NRR is more important. So why are we measuring cup disc ratio? As cup size in a small disc may be significant, or symmetry of cup more than 0.2 is significant, and increase in cup over the time is significant. Any abnormality in shape of the disc should be noted while assessing the parameters. The NRR is most important aspect in assessment of glaucoma. If there is violation of the isn't rule, then there is a high suspicion of glaucoma. As you can see, the pallor in both these pictures is not a feature of glaucoma, except in very advanced glaucoma. Retinal in the form of the focal notching. Sometimes notching, we can see the which is called optic disc pit. Third, high a retinal nerve I will later see that striation and artery is best seen in red free light, which is focused just anterior to the retinal vessels. Other effects are wider than the retinal vessels and extend to disc. Fourth is halo. To presents peripapillary atrophy, the zone beta is more significant with respect.
I think she has lost the connection.
Yeah, we lost the video.
Yeah, we can give her time.
Yeah.
Half a minute or so we can alert her. Hi Ria. Are you there online?
Is the presentation visible, sir?
No.
We had lost the connection in between.
Okay. So continuing, hemorrhages.
Yeah.
Flame-shaped
Presentation is
hemorrhages
not
are
visible. We can hear you, but we cannot see the presentation. Yeah. So start sharing the screen.
Is the presentation visible, sir?
No.
Not yet.
Wait a minute. Just a second. It's sir?
It is getting started. It is not seen yet.
Is it visible?
So no, it is getting started. I think the internet is slow. Yeah, we can see the screen now.
It is visible?
Yes, we can see the screen now.
Is it visible?
Yeah, it is visible, but only the screen is visible.
Okay.
Yeah, it is visible. You have about 45 to 50 seconds left. So you have to finish within that.
Is it visible?
Yeah, it is visible now.
Yes,
nasalization of vessels. Nasalization of vessels, as you can see, compared to the right side, which is the normal image. Then bayoneting. Bayoneting refers to bending of vessels over the overhanging margin of the cup. It is so called as it resembles the bend of a bayonet of a rifle. In later stages, there is development of a bean pot cupping where you cannot see the climbing vessels. The term overpass cupping is used when the vessels on the disc, unsupported by posterior tissue, pursue relatively undeviated course over the surface of the cup. Bearing of the circumlinear vessels is seen. As the cup enlarges, an area of pallor appears between the vessel and the cup margin. And finally, the laminar dot sign, where the openings of the lamina cribrosa may be visible as the nerve fiber layer atrophies. You can scan the QR code to get this PPT on your device. Also, there is a QR code if you want to give a feedback regarding my presentation.
Nice presentation, Ria. Judges, please ask the question.
Ria, no need for the feedback. We are going to give it immediately. As you said, you are a passionate as a teacher. Can you hear me, Ria?
Yes.
Yeah. So
Yes,
though
sir,
the presentation was interrupted in between, I could sense the passion. I want you showed one slide, and with the help of that, or with any other help, can you explain to me why the cup is formed? How do you explain the presence of a cup on the disc to a student? We are talking to teachers. I'm talking to a teacher. So I want you to explain to me why there is a cup to begin with. Why do I see a cup when I see evaluate the optic disc?
Yes, sir. So cup is formed by the fiber. Can you see the screen, sir?
Yeah.
So cup is formed by the nerve fiber layer, and there is mostly vertical elongation in the cup. As the lamina cribrosa, as you can see in the image, it has more larger pores in the poles, superior and inferiorly, having less nerve fiber layer and having less connective tissue for interruption. That's why that cup elongates more vertically.
No, you did not get my question. Actually, can you show me the slide on which you showed a pot, a earthen vessel?
Yes.
The bean pot, I think so. Sir.
Yeah, the bean pot thing that you're showing. Yeah. It's okay. I don't want to go to take much time. What I wanted to ask you is how will you explain that the cup is formed? So you can use that pot to show the fibers going in and the space that is created in between. So as a teacher, I thought because you were interested as to how would you explain that. It's okay. So thank you. I'll leave it to Anil and Shruti.
So Ria, can you hear me?
Yes, ma'am.
Yeah, nice presentation. Just that there was some disruption in between, but otherwise good presentation. So can you judge the cup disc ratio with respect to central retinal vein thickness? Is there any guideline for that?
Not that I'm aware of, ma'am.
Okay. How much is the diameter of the central retinal vein, if you can just tell me? No problem.
Yeah.
Yeah. So, yeah, nice presentation. Nearly all points were covered. But I had a very small, simple question. If a patient with 80% glaucomatous cupping gets raised intracranial tension, would he get papilledema?
Pointed cup with raised intracranial tension.
So both things are opposite. Glaucoma is causing cupping. This is causing swelling. So what happens? Like, would he get?
No, sir, not that much.
Most likely not. Right. Good. Correct. So if the cupping is more than 80%, it doesn't tell us anything about the intracranial pressure because that wouldn't be seen on the cup as such. Okay.
Yes.
So nice presentation. We
Thank
can
you, sir.
move. Vivek?
Yeah, it was a very well depicted in the slides. You had prepared very nice slides. Your
Yes.
knowledge
Very
will be
nice.
judged, of course, by the judges. But I can tell you that the presentation was very good.
Excellent. Yeah, it was.
Yeah, it was very good. Yeah, Saurabh is ready.
Yes. Sorry.
Yeah, so I request Saurabh to go ahead with his presentation.
Yes. Hello. Morning, everyone. Hello. Audible to you, sir. Hello, everyone. Audible and visible.
Your screen is visible, but the presentation is yet to open, I guess.
Hello, everyone.
Yeah, now it is visible. Just do it on PowerPoint mode.
You can make it full screen. Saurabh.
Yes, sir.
You can make it full screen. We are able to see your presentation first slide. Make it full screen.
Sir.
Yeah.
And happy Independence Day to everyone. I am Dr. Saurabh, PG resident, SMBT Institute. The topic for today is related to one of the most popular procedures in today's world, and that is laser refractive surgeries and discussing the contraindications of laser refractive surgery. So, why is discuss this topic? So, as I feel, because as a doctor, several times you will be asked relatives or any of your patients regarding just that I want to do, I want to get spectacles or contact lenses. In that case, you must know which are that are to be taken to advise someone on refractive surgeries because everyone will not be able to undergo these surgeries. There are limitations of refractive surgeries. So some common laser refractive surgeries are LASIK, that is laser insufflated keratome, epiLASIK, that is laser keratomiliosis, that is laser subepithelial keratomiliosis, so refractive keratectomy, and then femtosecond refractive surgery. So we'll go to the contraindications. So there are some absolute contraindications which are generalized for all the refractive surgery, which are the following. The corneal abnormalities such as thinning of cornea, conus, corneal ectasia. Then in a history of herpetic keratitis or any zoster ophthalmicus, in keloids, corneal keloid, which are mostly contraindicated in photorefractive. Then cataractus lenses. Then in pregnancy and lactations, these procedures are to be contraindicated in case of drug usage such as isotretinoin or amiodarone. These surgeries will be contraindicated. In case the patient's age is less than 8 years and an unstable refractive error, procedures are contraindicated. So there is no in children's less than 80 years of. So relative contraindications regarding this refractive surgeries are first of glaucoma or other glaucoma suspects, or in case of also. In case of uveitis, severe dry eyes, contraindicated. Procedures are also contraindicated in autoimmune procedures such as Zika syndrome or Sjogren's syndrome. Then lupus disorders, arthritis, systemic conditions such as HIV or diabetes. These procedures are contraindicated. So now most of these indications are to follow generally all the refractive surgeries. But to discuss particularly certain refractive surgeries, there are particular contraindications also, which I try to explain. Common procedures are laser in situ scoliosis and photorefractive keratomy. So in laser in situ keratomy, corneal flap raised and the apicary position. Henceforth, the refractive error is correct. In photorefractive keratectomy, the laser over the corneal space. There is no flap. These procedures. So they both share some indications, but there are indications which both these procedures. For example,
You lost him.
We'll have to wait a while.
Yeah, I think.
Actually, we had instructed them sit in an area where there is a good connection.
Yeah, that's the basic crux of the thing. If there is a good connection, it's like a physical meeting. If there is not a good connection, then it becomes.
Yeah.
But still good. Most of it is covered. Like
Yeah, most of it is covered, and we can give. We have planned accordingly. We have some spare time. We have kept 2 hours for that.
That's
Logically, our presentation should get over within 60 to 70 minutes. So we have 40 minutes more.
More, yes.
So already planned for these delays. Yeah, go ahead, Saurabh.
Shall I continue?
But your screen is not visible.
Am I visible now?
Now you are visible. Start sharing your screen.
Send me here.
I'll need a moment, sir.
Yeah, you take your own time. Yeah, you were about to share basically. Now your screen is seen. Yeah.
Is it visible?
Your
Yeah, it is
screen is
visible.
Yes.
So, sir, I was going to tell about contraindications, basic and PRK particularly. For example, in service personnel, if he to be advised for a refractive surgery, we should go for refractive keratectomy. Is mostly contraindicated in such. And for example is of a keloid formation, which I discussed earlier, generalized contraindications to surgery, which in can go for a LASIK procedure. In case of recurrent corneal there is a big no for LASIK, but keratectomy can be done. In case of refractive error, LASIK is the procedure of choice. Mostly in case of myopia. Whereas in photorefractive keratectomy, high myopia will good results. So the next procedure is laser subepithelial keratectomy. In this procedure, the corneal surface is hello. Absolute contraindication for LASIK are exposure keratectomy, severe dry eye, and herpes zoster. Whereas relative contraindications are uveitis, glaucoma, or cataract. One very popular procedure in today
So you have to conclude.
is femtosecond
You're
laser.
running out of time.
Yes, sir. So in case of small fiber aperture, subluxated or dislocated lenses, attention deficit disorders, or rather small pupil and glaucoma, femtosecond laser is to be contraindicated. There is a big no for cases. So by my topic. Thank you so much.
Judges, please.
Yeah.
Go ahead.
Saurabh a little interrupted the presentation, but I didn't catch. Did you talk about corneal topography? And how much of key reading is acceptable to correction for contraindication? I didn't get you on that point.
Sir, in case of LASIK,
in case of LASIK, please.
Hypermetropia up to plus diopters.
No, I'm asking about the curvature, the K readings. No, I can't hear you.
Sir, if the corneal curvature is steeper than 40/70, we should rule out the surgeries.
Yeah.
Because it lead to or post LASIK ectasia.
Yes, and
if it is and less than 13 diopters, flatter than 13 diopters should all be done.
Yeah, but if you have a small error and you have 42, what do you do?
Sorry, sir, I am.
Is the error and the curvature related to a contraindication?
Can you please repeat?
Okay, I also can't hear you very well, but okay, I think we'll leave it at that so that others can ask a different question.
Saurabh, can you tell me wherever there is LASIK contraindication, what other options or modalities are there for refractive error correction?
Can you repeat the question?
In cases of contraindications of LASIK surgery, what other treatment modalities are available for refractive error correction?
Ma'am, just in case of a military person or a sports person, so the LASIK is contraindicated. We advise him photorefractive keratectomy also. And also,
Yeah, just enumerate those. Just tell me the names. Other options.
in case of current corneal, if the patient is having history of corneal erosions, can advise him photorefractive keratectomy instead of LASIK.
Anything else?
And if the cornea is thinner, can advise to go for epi-LASIK also in place of LASIK.
Okay.
Sir, any other commonly used drug being used?
Drugs such as, sir, one is retinoid.
The use which is very common is inject.
Please repeat the question. I was not able to hear you.
Yes. You talked about isotretinoin as a medication for LASIK surgery, right?
Yes, sir.
Can you hear me? Hello? Saurabh?
Hello. Yes.
Yeah. Can you hear me? Hello?
Sorry, sir. I was not able to hear you.
Okay, just tell me if the patient is on isotretinoin, then what you do, you stop the drug and do, like, can you stop the drug and do LASIK?
Sir, I don't have much about it, sir, but
Yeah, okay. Basically, you stop the drug for 6 months and then you can go ahead and do LASIK. So it's a relative contraindication. Absolute contraindication when the patient is taking it, but you can stop and then you can go ahead and do LASIK after 6 months time. Okay, can you hear me, sir?
Yeah.
Yeah, so your presentation was good. You made an exhaustive list of LASIK contraindications. Probably 10 out of 20 patients would go out of the window if we follow that list, right? Hello?
Hello, sir. Yeah.
Yeah. Good presentation. Right.
Thank you, sir.
ऐकू येत नाही नीट. We can't hear.
Your net is also interrupted.
माझं पण ऐकू येत नाहीये.
तुमचं पण मध्ये मध्ये इंटरप्ट होते सर.
अच्छा. Should I repeat it?
No, we could listen it because you repeated it twice. The drug has to be stopped for 6 months.
Yeah, so it's not.
There are so many relative contradictions. At least half of the patients will not be fit for the LASIK. That message we could get it from you. Anything else you want to tell?
It's a good list.
So, who is the mentor of SMBT college? Saurav, who is your mentor?
Sir, Dr. Shubhangi Sathe.
She is there online. Dr. Shubhangi is there right now.
So Dr. Shubhangi madam is on another judge in another session, I think.
Okay. So I think Manish sir, you are free now.
Yes, I am in the session for quite some time now.
So so please, I request Manish Bape sir and Dr. Kunal Nikale to please conduct the further session.
Sir, the thing is going very smoothly. Why?
Yeah.
Please continue, sir.
More smoothly once you.
We are there. We are there. Continue, sir. Please.
Yeah, please. No.
Things are going very smoothly. I don't want to.
You are the chief coordinator of today.
No.
For time being, I was replacing you. Please continue.
Okay. Just hang on then. Let me check the list. Do you have the list with you, sir? Can you ask?
Yeah, I have. Next speaker is Chaitali Arakne, Pravara Medical College.
Yeah. Is Dr. Chaitali there?
Yes, sir, Dr. Chaitya. Okay.
Yes, Dr. Chaitali. Can you start with your
Yes.
presentation?
Yes, sir. Yes, sir. Is my voice audible, sir?
Yes, yes. Can you please share
Yes.
your screen?
Yes. Can it be seen?
Yes, your screen is visible. Just go to full screen, please.
Yes, sir. Yes, sir. Is it visible? Yeah. Good afternoon, everyone. I'm Dr. Chaitya Aranke, and we'll be learning corneal anatomy and its clinical significance. The cornea is a transparent avascular watch glass-like structure that refracts and transmits light. It is covered anteriorly by the tear film. The tear film is it comprises of 3 layers, and any imbalance in one or more of these layers can result in a dry eye disease. Coming to the embryology of the cornea, the corneal epithelium is derived from the surface ectoderm, and the stroma and the endothelium is derived from the neural crest cells. This is the histological photo of the cornea. The nerve supply of the cornea derives its nerve supply from the ophthalmic division of the trigeminal nerve. This is a post-operative photograph of penetrating keratoplasty, in which the full thickness of the recipient cornea is removed and the donor cornea is grafted onto the recipient cornea. And since it is a full thickness, there is cutting of all the corneal nerves, and so it takes a long time for the corneal nerves to regenerate, and not all of them get regenerated. And the wound healing takes about 6 months, and selective suture removal can be done after 6 months. The cornea is an avascular structure, and it derives its blood supply from the limbal vessels. These are the properties and functions of the cornea. Coming to the layers and the clinical significance of the layers, this is the XYZ hypothesis for the corneal epithelial homeostasis, in which X is the basal cell proliferation and Y is the centripetal movement of the transient amplifying cells, and Z is the desquamation or the loss of the surface cells. So X plus Y should be equal to Z. That is, the regeneration should be equal to the loss of the cells. In pterygium and band-shaped keratopathy, Bowman's layer is involved. Now here we can see stromal edema after phacosurgery, and in the second photograph we can see bullae associated with stromal edema. Bullae is an epithelial finding. Dua's layer has assumed a lot of importance in deep anterior lamellar keratoplasty, in which the deeper layers of the cornea are retained and the superficial layers they are removed and grafted onto. Now this is the diagram of the basement membrane detachment associated with the corneal edema. The endothelial cell count and the endothelium are extremely important for the integrity of the cornea. The endothelial cell count is about 4,000 to 5,000 cells per millimeter square at birth, and they decline with age at a rate of 0.3 to 0.6 cells per millimeter square. By the end, it's almost like a count of 2,000 to 4,000 cells per millimeter square is left, and 400 to 500 cells per millimeter square is the critical value required to establish the transparency of the cornea. Endothelial cell count is extremely gets compromised in intraocular surgeries. Coming to the dimensions of the cornea, the diameter of the cornea, the horizontal diameter is 11 to 12 millimeters, while the vertical is 9 to 11 millimeters. The thickness is 0.5 millimeters centrally and 0.7 millimeters peripherally. LASIK surgery is contraindicated in thin corneas. Anteriorly, it is elliptically shaped, and posteriorly, it's round. The radius of curvature is 7.5 to 8 millimeters at the center optical zone. Collagen cross-linking is done to prevent the progression of ectatic conditions of the cornea. Ectatic conditions means the worsening of the basically the thinning of the corneal layer as the condition progresses. Coming to the transparency of the cornea, I'll discuss the anatomically relevant points. The arrangement of the stromal lamellae are arranged orthogonally to each other, and the collagen fibers are regularly spaced and
the arrangement of fibrils in the cornea are the density and the diameter of the fibrils is consistent, and the transparency of the cornea can be attributed to that. And the anterior stroma is more compact than the posterior stroma. The cellular factors affecting transparency are the keratocyte, which have the crystallins, which
Chaiti,
contribute.
please wrap up. You are going over time.
Yes, sir. I'm done. Thank you so much, sir. Yes, sir.
Yeah, good presentation, Chaitali. First and foremost, I am very happy that this is the first presentation which I could hear completely. And
yes, that's right.
And it's comes from a small place like Pravara, so that's very good.
Yeah.
Yeah. I would have asked you a question on that, but before that, can you tell me something about corneal hysteresis?
Sorry, sir. Corneal.
Can you tell me something about corneal hysteresis?
Corneal hysteresis.
Yes.
Yes, sir. Corneal hysteresis, we can, it is basically the property of the cornea that it is, there's a property of viscous elasticity of the cornea, basically. And hysteresis is, it is the strain which is brought about due to the shearing stress on the cornea. So basically, when we say it is viscoelastic, means when we are deforming it, it will return back to its original conformation.
Yeah, very good. Very good. Yeah. Please go ahead, Anil. Shruti.
Yeah. Shruti, ma'am.
Yeah, so whenever in cases of corneal anesthesia or when there is a sensitivity of the cornea is reduced, what will happen?
If the sensitivity of the cornea is reduced, basically, if there is a trauma, it won't be recognized that easily as we could have if the innervation was intact. So in that case, the condition can worsen and the disease can, or the pathology can progress in that case.
Okay. Chaiti, can you tell me two significant 2 points of clinical significance as far as corneal nerves are concerned? Anything?
Yes, sir.
Corneal nerves?
Yes, sir. The innervation of the corneal nerves can be compromised in case of herpes simplex keratitis, and in case of neurotrophic ulcer.
Neurotrophic ulcer is because the nerves are okay. But is there any kind of a spot diagnosis when you see some thickened nerves running with a corneal ulcer? What we call as radial keratoneuritis in patients of acanthamoeba bug ulcer. You get thickened nerves. Okay.
Yes, sir.
Secondly, in diabetic neuropathy, you don't get any nerves in the cornea. So.
Okay, so sorry.
Yeah.
Yes, sir.
So nice presentation, Chaiti.
Yeah, very good.
Thank you, sir. Can I stop sharing, sir?
Sure. Yeah, just a minute, because you mentioned Dr. Dua. Do you know Dr. Dua?
Yes, sir, Dr. Dua, sir.
Yeah, he's from Nagpur and then from BJ. Then now in England. Yeah, he's one of our this from Maharashtra. Yeah, in Nottingham, Queens. Very, very good.
Yes. Yes,
yeah.
Sir.
Okay, good presentation, Chaiti.
Thank you, sir. Thank you very much, sir.
Vivek? Hello?
So all the judges are done?
Yes, sir.
Hello?
Yes,
Vivek, we are not seeing it. Okay.
Pardon?
we are not seeing the timer, so I don't know whether she finished in time or not. So I think that's you can correct. You
No,
can.
no, see, once we interrupted, she stopped. So we can assume that she stopped in time because Manish was, yeah. Ankita is ready with the presentation.
Yes, sir.
Yeah, please share your screen.
Yes, sir. Sir, is my screen visible?
Screen is visible.
Yes, but your presentation is yet to open.
Is my slide visible now?
No, slides are not visible.
Not yet, not yet.
Just a second. Just a second, ma'am.
Yeah. Meanwhile, Dhanalakshmi, you are there?
Doctor.
No. Do we have to complete up to 2 only, or we can extend for 5-10 minutes?
No, I'm completely 4 minutes only.
No, 4 minutes for the student.
Yeah.
So how long we can conduct the sessions? So we will have to finish within 2 o'clock or before 2 o'clock, or we can extend for 5-10 minutes.
Oh, no problem, doctor. You can extend the 5-10 minutes.
So yeah.
Can I start my presentation?
Yes, please.
Good afternoon, everyone. My name is Dr. Ankita Shirude, and I will be discussing about vitreous substitutes. So what is vitreous? Vitreous is an inert transparent jelly that fills the posterior cavity of eye. It is composed of water, collagen, and hyaluronic acid. It is a hydrophilic gel that serves optical, mechanical, barrier, and nutrient function. So when do we need to substitute vitreous? When the loss is more than 2 ml as a replacement of natural vitreous or to exchange the opaque one. Intra-op, it is used to re-establish intraocular volume as an agent to reattach the detached retina or to mechanically remove the epiretinal membrane. Post-op, it is used after vitreoretinal surgeries. What is an ideal vitreous substitute? It should be viscoelastic, optically clear, one-time implantation, allows the movement of ions and electrolytes, non-toxic, non-biodegradable, and biocompatible. It should be readily available at reasonable cost and stable during storage. These are the types of vitreous substitutes. Starting with intraocular gases, non-expansile are the first choice of RD and PDR treatment, and expansile are used in giant retinal tears and trauma. Gases have the highest surface tension, so they maintain an internal tamponade effect and are excellent as short-term substitute. They do not tamponade the inferior retina, and to do so, the patient should be advised head-down position. The gases reabsorb spontaneously and should be avoided, thus they avoid second surgery for removal. The expansile gases should be avoided if the patients have intention to air travel. Silicone oil. They have high surface tension, so they create a tamponade effect only on the superior retina. They have antimicrobial activity and can be used in endophthalmitis. The refractive index is 1.4, so they require optical adjustment. In pseudophakic eye, in presence of silicone oil, the eye becomes hypermetropic, whereas in aphakia, the eye becomes myopic. Silicone oil removal should be considered after 3 to 6 weeks. Otherwise, it may lead to complications like cataract, glaucoma, or corneal decompensation. The removal should be followed by BSS or the air fluid exchange, or it may lead to retinal detachments. If silicone oil undergoes emulsification, it may also cause inverse hypopia. Perfluorocarbon liquids. They are effective only for intra-op repair of complex retinal tear because they disorganize the retinal structure. They allow the easy visualization and tissue manipulation during surgeries. They have also shown neuroprotective effect on animal studies. Semi-fluorinated alkanes. They have high interface tension, so they can bridge the retinal bricks. They are soluble in PFCl, hydrocarbons, and silicone oils. The refractive index is same as that of vitreous, and it has shown to be less retinotoxic.
Balanced salt solution is used as an irrigating fluid. It maintains the intraocular volume and pressure, but offers no tamponade effect. Experimental substitutes. Clinical research for vitreous substitutes has essentially tried to reproduce two aspects of original vitreous, the molecular structure and the chemical and physiological properties. This approach has led research towards functional biomimicry. Natural polymers provide good compatibility and can be used as drug delivery devices, but they have tendency to degrade rapidly, so cannot be used on long term. Hydrogel. These are hydrophilic polymers and are promising biomaterial for drug delivery. Transplants, correctly stored, the vitreous body maintains its structure and its enzymatic property because of its low inflammatory reaction. Regarding implants, bioengineering studies have shown interesting results like the foldable capsular vitreous body. So to summarize, the endotamponade agents utilized on regular basis have demonstrated to be effective in retinal attachment, but they substantially differ from the human vitreous, resulting in various complications. Nevertheless, recent advances have demonstrated the potential of hydrogels for the fast and wide range of therapeutics. Thank you.
So you were exactly on the time. Judges, please go ahead with the questions.
Yes. So, Ankita, what are the types of silicone oils available? Are you aware?
Silicone oil combinations.
Right. What is the normal percentage of silicone oil? It is measured in centistroke, right?
Yes, ma'am.
So how much do we use? Is there anything like high density silicone oils?
Yes, ma'am. The heavy silicone oils, where the silicone oils are
What is the
mixed with
normal constitution? Like what is the normal centistroke of silicone oil which we use generally?
the silicone oil structure is of 3,000 to 5,000 chains.
So that is what high density silicone oils. Normally we use 1,000 to 1,500 centistroke.
Yes, sir.
And what are the complications of silicone oil?
Ma'am, silicone oil, if it undergoes emulsification, it may cause inverse hypopure. And if the patient has IOL, it may also adhere to the IOL. Silicone oil, if it comes into the anterior chamber, it may cause corneal decompensation and keratopathy. It may also cause cataract and glaucoma.
Yes. Okay. Any refractive error changes it can lead to?
Yes, ma'am. If the patient is pseudophakic, then it causes hypermetropia. And if it is aphakic, then it causes myopia.
Okay, good. Sir, if you want to.
Other judges?
Yeah. Can we use vitreous from a donated eye as a vitreous substitute?
Yes, sir, if it is stored properly.
Would there be any chances of getting some problems with that? Okay, it has been used previously initially, but then it led to inflammatory reactions, so it was abandoned. Okay, but your presentation was nice, very well presented and all encompassing. Everything was included, and most importantly, you finished in time. There is a good presentation.
Thank you, sir.
Raichur sir is there?
Yeah.
Harish sir, are you there online?
Harish sir is not there?
Yeah, and I'm there online, but I think I lost the meeting for a minute somewhere. I am back now. Kaitri, something connection with the Kaitri Bhotik problem. It's okay. We'll go with the next presentation.
Your question.
No,
no, nothing.
Do we have your mentor right now on the line?
Yes, sir.
Pagal madam, na?
Yes, ma'am. Bengal.
Madam is there. Madam, I will request Madam to say a few words.
So Madam had some domestic issues, so I don't know whether she is there.
Okay, so we can continue with the next presentation. Dhule team is ready. ACPM Dhule. Dr. Gaurav. So
Yes.
Dr. Gaurav, please start sharing your screen.
Okay.
Gaurav will be speaking on different dyes in the ophthalmology.
Is it visible?
Yeah.
Okay. Good afternoon to one and all. I'll be speaking about dyes in ophthalmology. I'm a JR2 and ACPM doer under mentorship of Dr. Varda Officer. So we'll be discussing about dyes using common practice in ophthalmology, what are dyes, and different types of dyes used across the ophthalmology. So dyes are chemical compounds that bind to various substances to the nature and induce color. So they are used in diagnosing of various conditions. They are efficient, non-invasive, and aid in visualization of ocular structure. So I have classified them based on their utility on ocular diagnostics and ocular therapeutical surgeries. For diagnostic, we have corneal and conjunctival staining, and we have retinal angiography. And for ocular surgeries, we have cataract surgeries, corneal surgeries, retinal surgeries, for LASIK, and for oculoplastic surgery. For conjunctival and corneal staining, we use fluorescent sodium is most essential and commonly used in ophthalmology, available in fluorescent strip, each containing 0.6 to 1 ml of sterile dye. Used for conjunctival staining, grading of corneal and conjunctival ulcers, corneal ulcers, for tear film breakup time, tear meniscus height measurements, corneal epithelial defects, abrasions, applanation tonometry, nasolacrimal duct patency, contact lens fitting, and Seidel test. Here you can see the strips. Another dye is commonly used is rose Bengal. Rose Bengal stain 1.3 mg of dye impregnated strips are used. It stains dead and devitalized cells, including mucous strands on the ocular surface. Stain is taken off wherever there is deficiency of tear film protection. Is used for evaluation of herpetic corneal epithelial dendrites, superficial punctate keratitis, Meibomian gland dysfunction, dysplastic or squamous metaplastic cells, and conjunctival squamous neoplasms. Here's some pictures. And it has dose-dependent toxicity and least tolerable. Another is lysamine green. It preferably stains the membrane, damaged or devitalized cell like rose Bengal. It's been shown that it doesn't stain healthy vital cells. It is less stinging and better tolerable than rose Bengal. For dry eye disease, for Sjogren syndrome and keratoconjunctivitis sicca. Another is used for fluorescent angiography. Fluorescence is extensively used for retinal vascular imaging. This form it is used in 10 to 20% intravenous injection bolus used for choroidal optic disc imaging, prime role in management in diabetic retinopathy, vein occlusion, and age-related macular degeneration. So before giving the intravenous bolus injection, emergency anaphylactic tray and sensitivity should be done. Here's the image. Another is indocyanine green. It has high affinity to collagen type 4 and laminin, which are found in internal limiting membrane of the retina. And it is highly protein bound, plasma protein bound, and it gives you a good visual of the choroidal blood vessel. Another dye is using, we'll go to the surgery aspect. Trypan blue 0.106% is FDA approved, and it actually used for anterior capsular rhexis, as it gives you a very good visualization of the capsular rhexis, and thus improving the surgical outcome. Also, we have a junction wallet marking pen for toric axis marking. And this we use for corneal surgery is same trypan blue used for Descemet membrane during stripping of endothelial keratoplasty, also used for staining and stripping of endothelium in DALC. And same in LASIK surgery, we use junction wallet marking paints for correct placement of the flaps. Here's the pen. And this is for vitreoretinal surgeries. Visualization of membrane is very critical, and For ERM and LM can be visualization of this membranes can be very difficult. A Trappin blue 0.15% solution is used for identifying ERM and delineating it. Brilliant blue G 0.05% is also used for identifying and removing internal limiting membrane. Although it doesn't stain the internal epiretinal membrane that good. This is stain. Another is triamcinolone acetone. This staining for vitreous is actually forming it's in a suspension form. It stains vitreous and used for vitrectomy. Another is andocyanine green.
Your time is over. You can just go through the list.
This is done, almost done. And it's also for internal limiting membrane. And last one is for oculoplastic surgery, which is junction wallet pain. Thank you.
So you were on time, no issues.
Yeah. Okay. So that was Gaurav?
Yes, sir.
Yeah. Did you mention vertiparin? Have you heard of it?
Sorry, sir.
Have you heard of vertiparin?
Vertiferin.
No.
Vertiferin.
Yeah. VERTEPERFIN. No? Oh, so it was used for photodynamic. It has not been done much nowadays.
Photodynamic therapy. I think
yeah.
so, sir.
Yeah, photodynamic therapy. Yeah, okay. Apart from that, I'm going to ask you a question regarding as a teacher, because this is a more of teachers for tomorrow.
Yes.
What difference in your presentation would you have made if this presentation was offline? How would you differentiate your online presentation from an offline presentation? In short, of course.
Sir, would have put.
Or you have not thought of it?
I would have actually demonstrated on it on a patient.
Okay. Okay. Good. But that you could do on online also. Okay, okay. Think about it, because you're going to have both modalities tomorrow. Sometimes you're going to have lectures nowadays with the new teaching pattern. Didactic lectures are going to go down. It's going to be one-to-one, directly patient-oriented, and framing of problems and then solving them. So you'll have to keep a little more, get a little more thinking into your presentation. Yeah, anyway, thank you. Good presentation.
I want to know the answer. What
Yeah,
I want to know
we'll
the
discuss
answer.
it.
What you are expecting?
Yeah, I will talk about it. We'll let the students go. We can ask somebody else also. So I'll come to that.
Let's keep it a secret till that time.
Yeah. we'll go to we'll keep it with the students now.
Okay. So Gaurav, that was a nice presentation. You nearly covered it all. Is there any specific stain or dye that you use for looking at the corneal nerves, which can be used elsewhere also in ophthalmology?
For corneal nerves, sir?
Like you can use a dye in, say, when you're doing endoscopic dacrocystoroenostomy, or doing fistulectomy after acute
Methylene blue?
Yeah.
Which is methylene blue?
Right. Correct. Absolutely right. The methylene blue would stain the nerves, and you can use it to stain the fistulous tract. You can use it to stain the inside of sac, so that when you dissect the sac area, you can delineate the sac very well and do sort of the kind of windows that you want to do in dacrocystoroenostomy. Okay.
Definitely.
So Gaurav, can you tell me what is the negative staining technique?
Negative staining technique used in cornea staining.
Can't hear you clearly.
And actually, it uses negative staining uses for
It is used in the retina surgery. So where do
used for macular differentiate between internal limiting membrane and epiretinal membrane in macular hole surgeries.
Okay. So how do you see that? The effect, negative staining? How do you differentiate epiretinal membrane and internal limiting membrane?
And there is a blue, you can differentiate.
G.
Yeah. So you
So
can
it's 10.
differentiate. Stain the internal limiting membrane.
Okay. And the ERM doesn't get stained.
ERM doesn't
That
get
is a negative staining type.
Yes.
Okay. Good.
So overall, it was a very nice presentation, Gaurav.
Thank you, sir.
Congratulations for that. Keith is ready with the presentation?
Yes, sir.
So please share your screen.
विवेक पुढच्या ह्याच्यात मी प्रश्न विचारणार आहे that will be sort of answer to the
Okay, sir. But I would expect the answer before.
Yeah,
we
sure.
finish
I'm going to. I
today,
will.
yeah.
Yeah.
So is it visible?
Yes, clearly visible.
Okay, sir. I'll start my presentation. Good afternoon, everyone. My name is Ketki Dautar, Junior Resident, ACPM Medical College. Today, I'll be presenting the topic Differential Diagnosis of Limbal Masses under the guidance of Dr. Surendra Vadgaonkar, sir. Today, we'll be discussing what is limbal mass, different types of limbal mass, and their treatment. What is a limbal mass? A limbal mass is any nodular lesion at the limbus that is a transitional zone at the junction of cornea and sclera. Causes of limbal masses can be congenital and acquired. We'll move on to congenital causes. First one is the limbal cause as limbal dermoid. As you can see, there is a whitish yellow mass which consists of epithelium, hair, and sebaceous gland. The treatment is surgical excision. Then we move on to nevi. It is flat or raised. It can be gray, gelatinous, or brown or black in color. It has the tendency to grow in puberty and pregnancy. It may undergo malignant changes. Therefore, surgical excision is advised. Further, we move on to inflammatory causes, which includes episcleritis. It is an inflammation of the deep conjunctival tissue. It can be nodular as well as diffuse. It is pinkish, elevated, and tender. It occurs in gout and rheumatism, and it can also occur due to endogenous allergy to bacteria. The treatment is topical steroids, NSAIDs, and systemic endomethacin. If it reoccurs, systemic therapy is advised. Next, we move on to scleritis. It can be nodular or diffuse. The nodular form is fixed to sclera. It can be associated with pain and uveitis. Causes are collagen disorders, endogenous infections, and the treatment advised is steroids. Allergic causes includes flictin, which is a pinkish nodule which is mostly surrounded by congestion. The symptoms include blepharospasm, photophobia, and lacrimation. It is an endogenous reaction to tubercular protein. The treatments include topical steroids and treatment of the cause. Next, we move on to venereal cataract. As you can see on the upper limbus, there are multiple small superficial spots, which is associated with a ropey discharge. It occurs in summer and common in children. It is a hypersensitivity reaction to endogenous allergen, pollen, and dust. The treatment advised is steroids, mast cell stabilizers, and NSAIDs. Further, we move on to ophthalmia nodosa. It is a granulomatous inflammation precipitated by certain insects and by the capillary hair. The treatment advised is steroids and excision. Next, we move on to hemangioma. It is a benign red lesion which blanches on pressure, bleeds on trivial trauma, and may be associated with hemangioma of lid or orbit. Next, we move on to traumatic causes, which includes granuloma. It mainly occurs after a surgical wound. It can also occur at the site of the foreign body. The treatment advised is surgical excision. Next, we move on to degenerative causes, which includes the pinguicula. It is a triangular yellow patch on nasal or temporal pterygium. It occurs in elderly. There is a highly infiltration with elastotic degeneration of the subconjunctival tissue. Treatment advised is excision due to cosmetic purpose. Next, we move on to cystic pterygium. It is a triangular sheath of fibrovascular tissue invading the cornea. The treatment is excision and autoconjunctival transplantation. Next, we move on to nutritional, which includes a bitot spot. It occurs in vitamin A deficiency. It is silvery white, foamy, cheesy patched with characterized epithelium, and it's present mainly on the temporal limbus. Next, we move on to neoplastic causes, which includes papilloma. It is a benign polypoid tumor which can be pedunculated or sessile. It can become malignant, therefore surgical excision is indicated. Next, we move on to squamous cell carcinoma. It is a granular growth invading the underlying structures. It requires early excision. Next is primary melanoma. It is in nodular form, may be pigmented or not pigmented. Surgical excision is the treatment of choice. Next, we move on to miscellaneous, which is the intercalary staphyloma. It is a bulge in the limbal area. It is lined by the root of iris due to ectasia of the weak scar tissue. It follows heel perforation injuries or corneal ulcer. Next is retention cyst. It is the thin wall cyst filled of clear fluid. Excision is indicated if there is excessive foreign body sensation or irritation or for cosmetic purpose. Thank you.
Judges, please ask the questions.
Yes. Ketki, nice presentation. In short, you have covered nearly everything. Good slides and good photographs too. So, but you in one slide of NIVA, you said it can undergo malignant conversion. So, what are the signs that NIVA is getting converted into malignant tissue?
Sir, it can show asymmetry and the border can be irregular. And it can undergo color changes.
Main change happens is it gets elevated. If it gets elevated, that means it's a suspicion that it can undergo malignant changes. Such. So an elevated NIVA is always under suspicion. So it's better to excise it and send it for history.
Okay.
Okay.
Yes.
So, Kiki, what is a Dellen?
Sorry, ma'am.
Dellen. Have you heard about it? Corneal Dellen or
no, ma'am.
DELLEN. It is a paralimbal excavation, saucer-shaped excavation. Do you know about it? Can you tell me how do you treat it?
Sorry, ma'am, I have no idea.
Okay. So you generally give a lot of lubricating drugs. Then either you can patch if it is not getting treated.
Yes.
And in addition to that, ointments. So that it will help healing it.
Yes.
Yeah, just in continuation of ma'am's question, have you heard about flicting? No, it's not there today, so I don't think in our days it was there. It was a elevation which was thought to be because of tuberculosis.
Yes, sir.
Elevation near the tumor. Yeah. Okay. That's okay.
Flicting has to be there in DD of limbal mass actually.
Yeah, it has to be.
It has to be there. It is very important. Yeah.
Yeah. And all the others, this of ocular surface
It was
neoplasm.
there, I think, in her slide.
Yes, sir.
It was there. Okay. Okay.
Yes.
Yeah.
So your mentor is there, Vadgaonkar, Dr. Vadgaonkar is there?
Sir, he's a judge in other session.
Okay, no problem. No problem. So Dr. Chandra Adwar from Pravara Medical, are you ready?
Yes, sir.
Yeah, please share your slide.
Yes, sir. Is it visible, sir?
Yeah, screen is visible. Your screen is visible.
Yes, sir. Good afternoon, everyone.
So the
My
slides is
topic
not. We can just see your screen.
Okay, sir.
Your slides are not visible.
Yes,
Open
sir.
the presentation and share it.
Is it visible now, sir?
Yes.
Yes, it is visible. You can go to full screen and continue.
Yes, sir. Good afternoon, everyone. I'm Chandra Advani. My topic is refraction in children. And why is it important? Because refractive error in children is the most common cause of reduced vision. It is responsible for 60 to 80% of visual impairment. So what is normal? In this graph, we can see the age in months in the x-axis and refraction in the y-axis. So a child the mean refractive error at birth is plus 2.25 and it can vary from plus 5.5 to minus 1.5. So one can be born with moderate hypermetropia, which is most common, severe hypermetropia, emmetropia, and myopia. So in the first 2 to 6 months, the visual development is rapid, and as the age progresses, the child attains 6/6 vision by the age of 6 years. So how do the child present? Child can complain of blurring of vision, inability to read, headache, stye, and the parents may complain of child sitting too close to television, squinting, poor performance in school, or rubbing of eyes. We start clinical examination with visual acuity assessment for near as well as far. Cycloplegic refraction is done, fundoscopy, and if child presents with squint, we should do the complete squint evaluation. So why cycloplegic refraction in children? Because most children have high amplitude of accommodation up to 12 diopter, and in hyperepic patient, eyes accommodate both in near as well as distance. Therefore, cycloplegic refraction is done to eliminate eyes' ability to accommodate. These are the cycloplegic drugs which are used in age less than 5 years. Atropine sulfate 1% ointment is used. In age between 5 to 8 years, homatropine 2% drop. And the age between 8 to 20 years, we use cyclopentolate hydrochloride 1% drops. The types of refraction in children: in objective refraction, there is static and dynamic. The static and dynamic indicate the state of accommodation of eyes. So in static, we ask the patient to look at object at 6 meters, or it can be done under cycloplegia. In dynamic, we ask the patient to look at object at less than 6 meters. The types of dynamic refraction: monoocular estimation method, Bell method, or Mohindra method. These are the choice of refraction in different age group. But the gold standard of objective refraction is the cycloplegic retinoscopy based on Foucault's principle. It is of two types: reflecting type, in which Priestley-Smith's mirror is used, self-illuminating streak and spot. What are the prerequisites of retinoscopy? Dark room, 6 meter long, trial set and trial frame, distant vision chart, and near vision chart. So how do we identify the type of refractive error? We see the direction of movement of reflex. If it is along the movement of retinoscope, the child, it can be emmetropia, hypermetropia, or myopia less than 1 diopter. If there is no movement, myopia of 1 diopter. If it is against the movement of retinoscope, myopia of more than 1 diopter. This is the AO guidelines for prescribing the glasses till age 3 years. But these values are on professional experience and clinical impression. The exact values are unknown and it may differ among age groups. So the principle behind hypermetropia correction is normally the child have high accommodation amplitude, therefore under correction is required. And if the child has squint, we should do the full correction. So in children younger than 4 years, usually the school age children, we should consider reducing plus for the refractive prescription by about 1/3. And if the child is older than 4 years, the child may not accept full cycloplegic refraction because of blurry distance. So it is first under corrected and gradually we increase the spherical correction in 6 months. In case of myopia, we give the full correction and it is never over corrected. So why do we treat the refractive error? To improve the visual acuity, visual function, visual comfort, and to prevent amblyopia and strabismus. So before prescribing glasses, one must take into account visual needs according to age, strong accommodative element, risk of amblyopia, age-related emmetropization, and associated conditions like strabismus. Thank you.
Yeah, all the important aspects were very well covered. Judges, please ask the question.
So, Chandra, nice presentation. Can you
Thank
tell
you.
me, in high AC by A ratio, suppose there is high AC by A ratio, which kind of glasses would you prescribe?
Ma'am will prescribe the
Yeah.
convex lens, ma'am.
Any special type of glasses you will prescribe?
Ma'am, bifocal.
Yeah. So bifocal and the intersecting that line for the distance and near should be intersecting at the pupillary, the inferior border of the pupil, or in
Yes.
the center of the pupil.
Yes.
Can
Chandra,
you tell me something about the Bruckner's test? What is the Bruckner's test?
Sorry, ma'am, I don't know about it.
That is done for amblyopia to differentiate between amblyopia and a normal eye. Okay, it is done by a distant direct ophthalmoscopy at around 1 meter, and in amblyopic eye you see a bright reflex through the pupil, whereas in the normal eye you see a little dull reflex. Okay, that is how this is a primary test by which you can exclude amblyopia in children. Okay, sir, you can go ahead.
Yeah. You have asked a good presentation, Chandra, and Madam has already asked you technical. And I'll just continue what I was talking with Vivek. See, if it is an online presentation, what are the main problems that you have when you're teaching online? Can you tell me, or Chandra?
Yes, sir. Sorry, sir, I can't hear you.
Yeah, when you're teaching online, what are the main problems that you have while teaching online as a
So we
teacher?
can't demonstrate. If it is offline, we can demonstrate.
Yeah, that is one. That point was taken, and I'll just elaborate. I'll just tell you that the 2-3 things that basically you don't know with the chances of the student losing his attention are very, very high because you can't see them. That is one. And secondly, when you're teaching, seeing, you know that whether the student is paying attention and whether he has understood. So here also, in between, you should be asking questions immediately, if possible, and getting response from most of the kids interactively as much as possible, because otherwise you don't know what's happening. And you should use all the power presentation tools or whatever I read nowadays of the AI tools that have come in, where that is, instead of direct presentation with a patient, you can use those tools to make it make the videos very interesting and very explanatory. So that always helps, and to understand and explain better. So this was the Vivek. That's what I wanted to convey. Yeah.
That means eye to eye contact is very important.
Yeah, so that is very important. Otherwise, if you don't, then at least you see to it that they're listening to what you're saying. So you ask a question in between, or ask them to put in a chat or put in a question and ask them to answer. So and put as many as demonstrative this into it.
It's more
Videos
interactive when you are in offline mode.
Offline, yeah. So as many videos so there are so many things that have come in. So you can that will explain things much better than otherwise. Yeah, that's what I wanted to say.
Thank you.
Thank you.
Sir? Yeah, nice presentation, Chandra. I have a very simple question to ask. If there's refraction of 2 eyes is different, then how much difference in power or difference in image size can the patient tolerate? You know what I mean? Suppose one eye has a +1, other eye has +4, +5, +6, 7. So can we give glasses to those kids?
No, sir.
So we can give glasses +1 to one eye, right eye, and +4 to the left eye, or +5, or is there a limit, or we can't do that? Did you get my question?
Sir, if it is less than 2.5 difference, then we should.
Correct. +3 or -3, that is difference. The image size tolerated by for binocular vision is a difference of 33%. That's what the limit. But practically, you can try it out on patient, and every patient may have a different tolerance. So they may fuse even with +5. Some may not even fuse with +2 or +3. So, okay, nice presentation.
Your mentor is there?
Yes, sir.
Yeah.
This.
Pardon?
Hello, good afternoon.
Sir.
Good afternoon, respected faculties. Yes. Myself, Dr. Akshay Bhandari, and my PG residents are glad and fortunate that they are able to present the topics in front of the MOS. So thank you very much. I am in a traveling, so network issue is there.
Yeah, one of your student has done a very good job.
Yes, thank you.
And now I'll request Anisha to continue the session.
Good afternoon, sir. 1 second. Just 1 second. So can you see my screen?
Yes, we can see your presentation.
Good afternoon, everyone. I'm Dr. Anisha Wagh, and today we will be discussing newer IOLs. I want to mainly discuss what was the need for the development of these IOLs and how they help us avoid dependence on spectacles post-cataract surgery. The material used in newer IOLs includes acrylic and silicon, which is not just foldable, but also has better UVL compatibility and lower chances of PCO formation, especially with hydrophobic lenses. They can also be used to correct presbyopia, and toric lenses can be used for a cylindrical correction. We have now moved to using aspheric lenses and lenses having blue blocking filters. An ideal intraocular implant should be biocompatible and also have optical and mechanical compatibility. So why are we using aspheric IOLs these days? Spherical abrasions are a form of higher order abrasions. The cornea has a positive assay, while the human lens has a negative assay. As we age, the assay of the lens becomes more positive, increasing the total ocular assay. This causes blurring of vision and a decrease in contrast sensitivity. Using aspheric IOLs, we can avoid this additional positive assay, thereby improving the quality of vision. Here is a chart that shows us all the IOLs that are available to us, and I will mainly be focusing on posterior aphakia correcting IOLs today. Monofocal IOLs have a fixed focus for one particular distance only. So how do we use them to correct presbyopia? This is by a phenomenon called monovision. Here the dominant eye is adjusted for distance vision and the other eye for near vision. The problem with this is that we lose binocular vision and stereopsis, but its advantage is that the visual disturbances are less. Multifocal IOLs can separate the incoming light into two or more foci, thus producing multiple coexisting retinal images. They can be bifocal, trifocal, or multifocal, or based on their principle, they can be refractive, diffractive, or hybrid. Refractive IOLs have various annular zones with different refractive powers that bring light to focus at different points. Diffractive IOLs are based on the mechanism of apodization, while hybrid uses a combination of the two. Refractive IOLs, the near vision they give is only fair, not excellent. So they should not be used for people who have prolonged reading, while the diffractive IOLs, the intermediate vision is fair, and so people who have a lot of computer-based work may not accept it very well. The main difference, however, is that refractive lenses are dependent on the pupil size, while diffractive lenses are less dependent on it. This is a checklist to keep in mind when you're recommending the use of multifocals in our patients, the main being that the patient should have realistic expectations of vision post-op. EDOF lenses produce a single contiguous elongated focal point, which enhances the depth of focus. They can again be pure EDOFs, which are refractive, diffractive, or have hybrid lenses. Their advantage is that photic phenomenon that we see with multifocals, like the halos around these lights, are markedly reduced. Toric lenses are used in patients having with the rule astigmatism more than 0.75 diopters, stable keratoconus, or astigmatism post-PKP.
They should, however, be avoided if the patient has any corneal or posterior segment pathologies, or if a rent or zonular instability occurs intraop. Accommodative IOLs can be a single optic or dual optic. In these, when the ciliary muscle contracts, there is a change in the position of the lens, changing its effective power. Whereas with deformable optics, on accommodation, there is a change in the shape of the lens and its true power changes. Liquid IOLs are still under study and something we can definitely look forward to in the future. I hope this was a concise and to the point explanation of newer IOLs, and I hope you all understood and followed through with me. Thank you.
Yeah. You are within the time, Anisha. It was a very good presentation.
Thank you.
I would request judges to ask the questions.
So Anisha, tell me one thing. If we use a multifocal IOL, would we get always less light for distance vision? Would there be a loss of light when you're looking at a distance image?
So for diffractive lenses,
No, compared to monofocals, any multifocal you take, are there any multifocals which will give you 100% of light for distance vision?
No, sir.
You know what I mean? Whenever
Yes,
you
sir.
are
No.
using multifocal, you are distributing the light in separate focus zones, right?
Right.
So now, when you are looking at a distant object, 100% light should fall on the retina. So, are there any multifocals which give you 100% of light on distance vision? Or in other words, let me rephrase it. Is there always some light loss of the image when you're looking at a distance object with multifocals?
Yes, sir, because the light will also adjust for different foci. The thing with multifocals is multiple images are produced and on the retina, and because of neuroadaptability, the brain is used to focusing on the most clear one. But there will always be some loss, and even though we are not looking at our near object, the image will be formed on the retina, although blurred, but some light will be dedicated towards that.
Absolutely correct. Exactly. Because that's why any multifocal you use, you are going to get not less than 10% of light loss for any image, or near or distance. So that is basically the point in multifocals is keeping this in mind only, you should choose your multifocal IOL patients. Correct us.
Yes.
Any newer IOLs regarding this light adjustments and this that you are aware of? Because the topic is newer IOL, ones which are, not still into the market, but being thought of.
So as I discussed in my last slide very briefly, the liquid IOLs
the
are still
fluid
under
one. Apart from that, I was just continuing with Dr. Nalgilkar's topic.
Right, sir. We also have so telescopic lenses are under study, especially for patients who are suffering from advanced ARMD, where we can put in a small lens equivalent to a Galilean telescope into one eye, so that the central vision is improved in that eye, and the other eye we'll prefer to put in a monofocal, or any other lens, so that the peripheral vision is clear with the other eye.
Yeah, there are some light adjustable lenses which are being thought of, blue light filters.
Sir.
And what would be the most ideal lens? It would be a customized lens, whether that is still not in, but that would be the next in line. Yeah.
So Anisha, very nice presentation.
Thank you, ma'am.
Yeah. Can you tell me the IOLs which are ideal for children?
I think I'm not 100% sure, but I would probably go for a monofocal, because with children, they're, playing outdoors more, and their distant vision is, we want better distant vision for them. They're not so much focusing on reading, especially at a much younger age group of less than 3. So 3 or 4. So that would be my preference, because
in children.
Sorry, ma'am.
Better to avoid multifocals in children.
Right, ma'am. Yes, ma'am.
Yeah, and any specific kind of material used in iOS which will be helpful for children?
Ma'am, hydrophobic lenses would be better.
And there are 3-piece lenses also.
Yes, ma'am.
Those can be used for children.
Okay, ma'am. I didn't know that. Thank you.
Okay.
So this was the last presentation. We are exactly on time. I would request, if now we are free, if anybody wants to talk, you can give your remarks.